As a psychiatrist who has had responsibility for managing large systems of medical care, I am personally familiar with the complexity, the urgency, and the very emotional nature of the issues that arise in the emergency treatment of psychiatric patients. Going to a psychiatric emergency room can be a very difficult experience, and what happens in that emergency room, especially what happens on the human side, can make all the difference in terms of that person's long-term health and well-being. My name is Dr. John Doherty, and I am the President and CEO of Comprehensive Neuroscience. Following a recent survey of the American Association of Emergency Psychiatrists members, we asked expert emergency psychiatrists for their recommendations regarding best practices in the psychiatric emergency room. A summary of the findings outlined in the Expert Consensus Guidelines series, Treatment of Behavioral Emergencies, was published in the May 2001 issue of Postgraduate Medicine. Now, while we were conducting that research, our faculty became acutely aware that by asking physicians for their opinions, we were only addressing half the question, and that we needed to ask the patients about their experiences and recommendations for psychiatric care as well. So, we embarked on a second research project in 2002 that involved interviewing and surveying 57 people who had experience with psychiatric emergency care in 75 cities across the United States. In the conduct of this project, we have had the pleasure to work with Dr. Michael Allen, past president of the American Association of Emergency Psychiatrists. A summary of the findings from this study were published in the January 2003 issue of the Journal of Psychiatric Practice. We believe the results of this survey can be very helpful for improving the emergency care of our patients and helping us fulfill our professional mission of relieving the suffering of those affected by mental illness. Building on these findings, we asked several consumers to appear on camera to describe their psychiatric emergency experiences and to tell us what helped, what didn't help, and what might help in the future. I think you will agree that their answers are very instructive.
My name is June, and I've attended Stanford and Vassar, and am currently working on my MSW. My mother brought me into the psych ER. I had gone off all my medication and was very manic and delusional and paranoid. It was terrible.
No one was really explaining to me what was going to happen, so I felt extremely isolated and alone, and I didn't know what was going to happen to me. My name is Kate Della Stover, and I am a poet, as well as a vocational coordinator for a mental health agency. For years, for a good part of my teens and 20s, I was hearing things, seeing things, just terrified. And then I ended up in the emergency room with none of my family or friends around, and it was terrifying.
How the surroundings look is important to any person in need of care, because for all of us it conveys a sense of respect and concern. But for people with a psychiatric emergency, these concerns are heightened.
First of all, the room is very sterile. It's very small. It's not very well ventilated. There are no windows or anything.
The carpeting was dirty. It was stained. The furniture was dirty, stained. You could smell. My name is Bobby Kuhn. I work as a program coordinator in the human services field.
Psychiatric emergencies involve a loss of one's own sense of self-respect and of a worthlessness. And that the person in a crisis like that is desperately looking for some outside help to restore their sense of worth.
Very often there's a nurse and she needs some basic information from you, so she'll just start talking to you like you're at the corner market. And here you are, here I am, let's say, in a tremendous amount of emotional pain, and a woman is sitting in a chair opposite me asking me a series of questions that I'm only partly understanding. And I feel like my foot has been amputated, at the ankle, and I'm bleeding, and someone is saying, "Well, that looks painful. How many buckets of blood do you think you lost on the way to the emergency room?"
I can't picture that anybody wouldn't like some comforting words, some feeling that what you're going through is not a good thing, and that we care about how this turns out. I'm Dr. Richard Police. I'm trained as a clinical psychologist. Probably the middle of 1995, I realized that I was under a lot of stress, having trouble concentrating. One day, I basically said to my wife, "I think it's time for us to visit a psychiatrist." We walked over to the then public psychiatric emergency room. The psychiatric emergency room itself is sort of unique. The nurses and the attendants acted like you were not there. No one really interacted with you, talked to you, acted like what you had to say had the slightest bit of importance. With a PhD, I had to convince people I had enough intelligence to talk about my treatment.
One of the things that happens in the emergency room is that we get very task-focused. And in that task focus, we often get very technically focused. So we're thinking about what medication do I use, how am I going to, get this total illness under control. What the patients were telling us is that we have to be complete treatment focused. And they don't want us to forget which medications, and they don't want us to give the wrong dosages of those medications, but they want to make sure that we remember the other critical part of treatment, which is establishing an empathic, humane relationship with the patient.
There were two psychiatrists doing the initial interview. They were conversing between themselves, ignoring the fact that I was in the room. It was sort of like two parents discussing how a child had misbehaved, and therefore the two parents needed to do something about it, but they weren't going to tell you what it was. You would be told later what was going to happen to you.
These concerns are an essential part of medical care. In psychiatry, we've known for a long time that the therapeutic alliance accounts for a large part of why people get better with psychiatric care, in addition to the specifics of that care, the type of medication, the type of specific psychotherapy. If you don't have the therapeutic alliance, those specific treatments don't have much of an effect. And what is the therapeutic alliance? The therapeutic alliance is creating a set of circumstances so that a person feels that they're understood, that they're cared about, and that what you're going to do to help them will really help them.
My name is Pat Colbert, and I'm a registered nurse. When I was 33 years old, I was brought in a psychiatric episode, which I didn't know what was happening to me, and I was delusional. I just remember my sister and my brother-in-law being at my apartment and taking me to the psych emergency room. When I got there, I remember that they had me on the stretcher, my arms and my legs tied down on the stretcher in the quiet room.
On my second admission, I think because things were too chaotic in their waiting room, because there were still inpatients there, maybe I was getting a little agitated, and they decided I needed to be by myself. So again, at a time when I should have been in contact with a lot of people, I was placed in a room that basically was a large closet with a chair and told to wait there. Well, when you're put in seclusion, if you weren't paranoid before, you are once you're in seclusion, because everything's now hidden from you in a way. You're by yourself. There's no one interacting with you. You've been cut off from the sensory experience. You're there. You're sitting there. You're waiting for what's going to happen next.
Now, one of the problems that emerges in psychiatric care, a quandary for the staff, is what to do when the person is really quite agitated and is likely to be a danger to him or herself or somebody else and needs to be held there against their will. And the patient now is more frightened because the last vestige of control that they have, the ability to leave, is being taken away. Fortunately, in our work, the patients, the participants told us what to do. And what they told us to do has to do with restoring a basic sense of trust and a clear sense that the people who are in that emergency room caring for that person really care. That involves having someone stay with the person, informing them carefully about the nature of the treatment that they're about to receive, letting them participate in each step in that process, listening to the person's story in the middle of this, and if possible, having friends or relatives, someone the individual trusts, close by. There are a number of things that are really important to patients that we heard about. One of them, of course, is choice. To the extent that the person can exercise that choice, they want to be able to exercise that choice. And they had clear preferences, for example, in terms of which medications they might like or what forms those would be in. In general, they preferred oral forms of medication over intramuscular forms of medication. But in any case, they wanted to be told about why that particular medication was being given and why it was being given in the form it was being given.
I remember these guys holding me down and medicating me, and I remember being very afraid that I was going to die.
People who had a bad experience in emergency rooms are much less likely to go back to them to seek care until they're much further along in their crisis. So it has an effect of inhibiting that treatment seeking, which we want to encourage. On the really positive side, there were a lot of good things that happened to these participants in the emergency room, and hearing about those was also very informative. Many of them didn't require a whole lot of time or effort, but made a very big difference in the person's care.
I can remember one aide in my first admission. It was within the first couple of hours after my admission from the psychiatric emergency room, who came in and just sat down next to me and talked to me for a couple of minutes. Those 2 or 3 minutes were more kindness than I had gotten beyond from anybody else.
There was a tech, and she was very honest. She told me she believed some of the things I said. She validated my feelings. She gave me hope. Even though it was just a little glimmer, there was still hope there.
My name is Andre Bailey. I'm on the board of directors of a community-based organization. They took me up to the community hospital, and all I can remember when I went into the ER is like I was just sitting there waiting and waiting and waiting. There was a nurse that actually, on her break, she went out and she came back and she brought me something to eat. I really appreciate her.
We asked about recommendations for improving care, and the participants had some very clear recommendations for improving care, which were very consistent across the different groups that we interviewed. Our survey found that the patients were very interested in having advanced directives available. Advanced directives are a way in which the person can express his or her preferences for care before a psychiatric emergency occurs.
It's a document where a person with a psychiatric diagnosis puts down what works and what doesn't work for them in times of great difficulty, so that if a treating physician or psychiatrist should determine that they lack the capacity to make healthcare treatment decisions, an agent who they choose, a particular person who they trust, can come in and communicate what I need in terms of medication, what I need in terms of physical touching. I do or don't like to be physically touched.
I think the doctors should work on that with their clients on an outpatient basis, so that when they do go inpatient, the professionals are better equipped to serve the needs of the person at the particular time, and what works for that person and what doesn't work for that person.
When I compare my experiences in an emergency room facility for a medical illness versus a psychiatric illness, there's some amazing contrast there. And when I remember going into an emergency room, actually the same emergency room for which my third admission occurred. And when I went there, We were talking about a medical problem, and the doctor came in, and they drew blood, and they told me they were going to be running a series of tests, and that probably in a half hour or so the test would be back, and then we would know how we were going to proceed. In the psychiatric emergency room, it was not a lot of conversation, lots and lots of waiting, no indication of how things were going to go and what I could expect the outcome to be. No one ever said to me, Rich, this experience you're going through right now is temporary, and that we have a way of helping you.
A psychiatric emergency is a crisis, and in the nature of that crisis, the outcome is critical for the entire future of the individual. And that's what the patient participants in this survey, I believe, were asking us to remember. They were asking that from the very start of care, we restore a sense of hope that life can get better.
Doesn't matter how bad you might be in any situation, there's always hope, no matter what. And if your doctor can't tell you that, how are you going to believe it?
This is a wonderful opportunity to say, hey, you know, I'm a human being. I'm going through a very difficult time. For long stretches of time, before you ever saw me in this emergency room, and after I leave whatever care you're going to give me here or on the psychiatric ward or at discharge or, you know, after discharge, whatever, I'm just a person who likes to walk in the woods and watch old movies and participate in life. I'm just a human being like anybody else.
I had actually gotten pretty far away from working directly with people in my own profession, other than teaching. My experience had moved away from private practice and working in mental health facilities. Having gone through it now, I've now professionally returned more to direct interaction with people, and giving people outside of the mental health community as much information as I can. When I see somebody in crisis now, the first thing I want to say to them is, I've been there, and I know how you're feeling. Not everybody's going to come back to the same level, but things can get better for you than they are today.
To recap, the consumers we surveyed made 3 major recommendations that can help us improve emergency psychiatric care. First, building a therapeutic alliance characterized by mutual trust and respect is critical for improving both short and long-term outcomes. Patients with a traumatic emergency experience often avoid care in the future, waiting until their illness is quite severe, before often then being forced to obtain treatment against their will. Tailoring the treatment plan to the individual is a key component of establishing and maintaining a therapeutic alliance. This involves eliciting as much information as possible from the patient, relatives if present, and referring physicians and therapists if at all possible. Including the patient as much as possible in the decision-making process is also an important way to strengthen and maintain a therapeutic alliance. Now, on another important issue, the consumers we surveyed in the acute care setting agreed with the physicians we had surveyed previously. They all said that, in general, oral forms of medications are preferred over intramuscular forms, but that no matter what is given, patients want to be told about why a particular medication was being prescribed. Second, the physical environment matters. Comfortable, relatively attractive physical surroundings are important because they convey a sense of respect for patients and can in and of themselves be soothing. Third, the consumers generally agreed that advance directives are of use in helping emergency care clinicians anticipate the patient's own needs in responding to an acute crisis. Now, we hope you have seen that there are many things that can be done to maximize a patient's ability to recover, and also, very importantly, be willing to seek care in the future.